do truly believe like AMD is a relatively manageable disease nowadays. And there's so much optimism because we finally have treatments for dry stage macular degeneration that we never had before. Back, I think it was like 2023, we had complement inhibitors, FDA approved for geographic atrophy, which we never had a treatment for before. And now we're moving more towards even earlier treatment in the intermediate AMD stage. We now have options of like photobiomodulation, low-level light therapy to try to slow the progression so that patients don't even get to the advanced stage if at all possible. So really exciting time frame in macular degeneration especially. I think our job as primary eye care providers is really to detect treatable features of macular degeneration. And so whether that's conversion to wet or exudative neovascular disease, that's absolutely critical, or the earliest development of geographic atrophy and referring as quickly as possible. We know the sooner we treat, whether it's neo or if it's geographic atrophy, the better the visual outcomes. So for us, I think it's twofold. There's in-office monitoring, which is critically important in detecting conversion to neovascular AMD, and that includes multimodal imaging. I think OCT is absolutely standard of care. Then, icing on the cake there would be like OCT angiography, fundus autofluorescence imaging, potentially fluorescein angiography, but close monitoring in office. And depending on the stage, so like intermediate AMD, if it's high risk, I'll usually monitor like every 3 months. If it's like early AMD, probably like yearly, give or take, just depends on the patient. But if you can complement that with home monitoring, so not just Amsler grid testing, but something like Foresee Home, where patients are closely monitoring their own vision, their results are being uploaded to a cloud so that you as the clinician are alerted if they have a change in their metamorphopsia at home, then to bring them in for an exam. I think it's absolutely like the best combination of home monitoring as well as in-office monitoring so you can catch the earliest conversion possible. One case specifically comes to mind. It was actually the grandma of one of my students when I was teaching in San Antonio. So she brings her grandma in. She's had 12 injections in one eye for macular degeneration. She wants to know if she should go for lucky number 13. And the vision of that eye is like count fingers or something. Like it's pretty far gone, like a lot of subretinal fibrosis. She's never had injections in her other eye. Her vision's good, like 20/40. Just looking at her clinically, I would have said it was like dry intermediate stage AMD. And then when I did OCT, there was this little bit of intraretinal fluid and a tiny pigment epithelial detachment. I then did OCT angiography, which revealed that there was like a really early area of neovascularization. So the whole focus of the examination was she came in thinking she needed more treatment in her bad eye, but we need to keep her good eye good. And I would not have known that that was neovascular exudative AMD. Did I not have OCT? Did I not have OCT angiography? I would have absolutely misdiagnosed that patient and potentially blinded her. I think with regards to like OCT angiography, initially it was that we weren't getting paid for the extra work that we were doing, but now there is a CPT code that you can get paid to do OCT angiography. However, there is like a cost investment too, because you have to have like a newer model of OCT in order to have motion tracking and get the angiography component. So there's that investment. But in my personal opinion, working with attendees in CE meetings, I think it's usually that there's a very steep learning curve to OCT angiography and getting comfortable with it. I mean, OCT in general, but then OCT angiography, there's no like normative database. Like it's not just you look at it's red, green, or yellow. Like you really have to understand what you're looking at, like understand the anatomy, understand the pathologic findings. And the sooner you jump in and you just do patients and get used to it, I think the easier it gets. But it is definitely a steep learning curve, I think. I do think that the schools well prepare students if they want to do OCT angiography, or practice like medical optometry in general. Education is definitely there. But then we see some of our graduates go out into practice where they're only doing refractions and they're really pressed for time. And then if you don't use it, you lose it type deal. And so sometimes I'll see attendees at like an OCT lecture and they're like, oh, I've been out of practice without an OCT for however long, and now I bought my first OCT and I need to know how to use this. And so, I see it at sort of both ends of the spectrum there.